Hello, everyone, and welcome to episode 38 of the Ortho Eval podcast. I'm your host, Paul Marquis, and today we have a special episode and with a great guest, Dr. Nick Arredondo, who is a neurosurgeon from Maine Spine Surgery, and he's going to be here to give us some tips on evaluating the cervical spine, looking at red flags, talking about some different other aspects of the cervical spine. Dr. Arredondo went to medical school at the University of Texas and also did his postgraduate work at the University of Florida. And welcome, Dr. Arredondo. Thanks for being on my show.
Thank you, Paul. It's great to see you again.
Now, I know you have a very busy schedule, and I really appreciate you taking the time to get on the show. I find that for our viewers and for those listening to our podcast, it's very important to get a different perspective on how we may evaluate or manage certain orthopedic issues. So, the premise to Ortho Eval Pal is to bring some pearls out there to help and guide people so it doesn't become so confusing. So we make the right decisions at the right time and try to expedite, the management of folks with cervical spine dysfunction. So that's kind of what we're going to be talking about today. And how long have you been working with Maine Spine Surgery, Dr. Arredondo?
Well, I've been here about 8 months now, and it's quite lovely. I've been really enjoying it a lot, and I got to say that the folks up in the county are tremendously lucky to have a resource like you and your organization up there helping them get better. And I think one of the first pearls to think about is that when a patient walks into clinic, they don't typically come equipped with a sign hanging around their neck saying, "I have a neck problem," or "I have a shoulder problem," or "I have a problem in my arm or my hand." And so I think, in terms of pearls, trying to identify what key things we want to pay attention to in order to think about spinal disease as a potential cause of their symptoms. The other thing, we talk about red flags, things that you might be worried about on a patient so that you might expedite their evaluation and treatment. Anything that involves a serious neurologic symptom, anything that involves profound weakness, profound numbness, or any other bodily dysfunction, really, especially in terms of the neck, we're looking at the fact that that spinal cord can actually affect pretty much every bodily function below the neck. And so that's I think, really the first thing to think about. And as we've talked about before, the body is tremendously complex. And while we have a pretty good understanding of some of the simple mechanical issues in the neck, there are a tremendous number of physiologic issues that are a little bit more opaque, and they can be somewhat difficult to tease through. And so I think, as we're looking at a patient, the first thing to try to understand is, what's the source of this issue, and is it something that's a structural mechanical issue, or is there some other systemic issue ongoing?
Right. I know that when they come in, I think the important thing is to ask the right questions right out of the block to make sure that you can tease some of these things out just in the subjective portion of your eval without even touching them. And, asking things like, paresthesias, do you have any tingling or numbness going down your arm? Well, rotator cuff tears and shoulder injuries don't typically cause paresthesias down the arm. So we need to really be thinking either neurological or vascular, and when you get the tingling down your arm, does it follow a specific pattern? Is it just the index finger and thumb, or is it the whole hand, which is more of a vascular type issue? So just asking those questions, I think, can be really instrumental in going forward with this patient so that you can kind of cut your evaluation from a 1-hour evaluation down to 10 to 15 minutes and really get to business.
Yeah, I agree wholeheartedly. And I think there are many great clinicians before us have pointed out that the patient will tell you what's going on if you take the time to listen to them. And obviously a good physical exam with some specificity of exactly what is the anatomic pattern of distribution of the symptoms, not just tingling into the hand. Well, the hand has a number of components. Is this a dorsal? Is this in the small finger, the small digit, or is this in the thumb? What exactly are we looking at? And the issue is, as you know, a lot of the symptoms we're dealing with are very common. People have these problems all the time.
Right, right. Now, as far as other red flags out there, are there any other, uh, symptoms that we should really be watching out for? Now, I know that some people will have loss of balance or incoordination. What about urinary incontinence and bowel and bladder issues? Are those things that we should ask during a cervical spine evaluation, and why?
Yeah, I think absolutely. Classically, we're trained that you have to be aware of cauda equina syndrome when we're evaluating lumbar patients. But I think that you can easily also get symptoms that are very similar and represent significant compromise of the spinal cord when you're evaluating cervical patients as well, and even thoracic. So absolutely, and the issue goes beyond just the tremendous impact that kind of dysfunction has on quality of life. The reality is that that's one of the few true emergencies when it comes to spinal disease, is that we have very few hours to try to correct a mechanical issue that's causing that kind of a syndrome. And once those a few hours pass, then unfortunately it's no longer an emergency. It clearly still needs to be treated promptly, but so that's really an important factor. And I think clearly any kind of red flag would be this patient that's had a significant mechanical trauma, motor vehicle accident, fall from a ladder, anything that would suggest a big event that would apply a tremendous force to their body. That's something that needs to be evaluated very promptly. Alternatively, if you have a patient that comes in and says that in addition to having strange pain, numbness, weakness, etc., they're doing things like they can't swallow anything, or they're throwing everything back up, or they're losing 20 pounds in a month, we start to worry. Unfortunately, today I just met a nice man who has a tumor in his neck, and that's how his cancer presented. And it showed up as neck pain. You can't see the tumor on the x-ray, but it's there. And so unfortunately, we worry about that kind of stuff. And alternatively, if you have a patient that has fevers and they just something else is going on, they're having fevers, chills, sweats all the time, they just feel lousy, but their predominant complaint is their neck pain. Well, you can get an infection in there as well, and that can be really problematic and very serious as well. And all those things require very prompt treatment.
Yeah. Now, while we're talking about these surgically urgent issues, let's talk a little bit about what type of patient and what do the signs and symptoms need to be before a PA or a FNP, physical therapist, occupational therapist, or a family physician. What does it take for us to send that patient to your office? There are a lot of things. Too often times I see somebody who is sent to your office, and I've been working with you folks for over 25 years and have learned what type of patient needs to be seen surgically urgent and who doesn't need to be seen surgically, who should be treated conservatively versus be referred to your office.
Yeah, absolutely. Absent those worrisome signs that and findings that we just talked about, I think it really, unfortunately, the landscape of medicine has really changed a lot. There was a period of time with the introduction of the MRI that people really felt that there finally was a definitive test that was going to give them all the answers to their questions. And unfortunately, the path of least resistance resulted in people using that probably in excess. And so now, as a result, it's quite difficult to sometimes convince an insurance company to pay for an MRI. And that's probably appropriate, because I think a lot of the times, most of these situations, the body is built for healing and it will have a high probability of healing. And I think one of the things that y'all do particularly well up there is help people tap into that ability to let their body heal and to help them in the process of it. So, I wish I could give you a simple answer. I think the reality is that if you have significant clinical concern for a patient, we're happy to evaluate them, and we'll take a look and we'll figure out what needs to happen. That said, we see a lot of patients that don't really need a surgeon. And that's good news, because we don't really want to be having everybody have spine surgery. That's probably not good for society either. So I think, these days, and I expect the landscape will continue to change over time, it just gets harder and harder to get the advanced imaging. And so really, I would say, what is your clinical concern? How worried are you for the symptoms? How serious are the symptoms? What's the pattern? Is this something that's been ongoing for 20 years and is about the same as it was last year? Well, maybe you take a little time and have them spend some time with a physical therapist or any other modality that you want to give a try to. I think it's not unreasonable. On the other hand, if you have somebody that had a fall a day or two ago and they have this progressive weakness and now they can't lift their arm over their head, well, that's probably a big worry, and we should really evaluate them soon.
Right. It was interesting because I just recently had a gentleman who had an MRI approximately 1 month ago, and with symptoms of radicular pain down the leg, and I know this is getting away from the cervical spine, but this just talks about diagnostic imaging and when it's important. And it was tolerable. The MRI came back perfectly clear, no signs of nerve root compression. 1 month later, the gentleman has intractable pain. He ends up in the emergency room. I take a look at him. He has significant new weakness. So we asked to get a new MRI, but I think the way we got that MRI quickly 1 month later after the other one was that we clearly talked about the red flags, that he had significant weakness into dorsiflexion, a significant straight leg raise test, loss of sensation, and loss of balance. Actually, the leg was giving way. So we were able to get a new MRI, and that new MRI showed a significant herniation of a disc that was just starting to prolapse before, but now completely extruded. And I think that it really comes back to, why do people not get better? Okay. And it comes down to doing a good clinical exam. And the number one reason people don't get better is because they're inappropriately diagnosed. And I think clinically, we need to step back and improve our clinical evaluation skills so that we can kind of tease these things out and make the proper decisions and manage these patients a little bit differently. And so I think, I think that evaluation is super important.
Absolutely. And and I think in particular with regard to the cervical spine, we have to keep in mind that pain in the neck does not necessarily portend terrible things from a structural and mechanical perspective. In other words, the joint functioning can actually be quite good in spite of a sometimes impressive amount of pain. Pain is a very difficult thing, and oftentimes the sources of the pain are not structural. They don't actually correlate with any of the findings that we find either on any of the objective testing. On the other hand, there can be some pretty significant spinal disease present in the absence of neck pain. And in particular, we talk about the syndrome of cervical myelopathy, where the average time to diagnosis in one study in particular was shown to be over 2 years from the onset of symptoms, simply because of the absence of neck pain. And even there can be symptoms like lumbar pain or lumbar radicular symptoms. And so I think that we have to keep that in mind when we're trying to evaluate these patients. And as I said, and as you pointed out, it's a challenging process. This is not a simple area of the body. We're dealing essentially with the central nervous system, and that's complex. On the other hand, I think if we follow simple principles, we can expedite and streamline things, and we want to do that simply because if you allow a patient to continue with, for example, radicular pains for an extended period of time, well, they will eventually start to develop weakness, atrophy, and even loss of sensation. And unfortunately, the possibility is there that they may not ever fully recover that function. So I think that, making sure that we pay attention as the patients are telling us what it is that's bothering them. We have to unfortunately keep that in mind, not just in the context of their physiologic being, but also in the context of their social experience, because it turns out that all these symptoms are going to be worse when your cat runs away, when your dog dies, when, some terrible thing happens.
Absolutely.
It's just going to get harder. So, I can't tell you how many times I've had a nice gentleman come in, 1 month into being a widower, that all of a sudden his chronic back pain that's been there for 20 years is much, much worse. Well, I'm certainly not going to recommend any kind of surgery at that time. We need to get through the healing process first.
Yeah, I actually do a podcast that's going to be coming up really soon. Or actually, I just did it, and it is going to be lined up here, and it's going to be on fibromyalgia and all those other factors that really play into this. So that's very important as us practitioners to understand the psychosocial aspect of a patient's life when evaluating them for these problems. Now, I have a couple of questions for you, and I didn't send these to you ahead of time, but I want your thought on this. Let's say somebody herniates a disc and they have an extrusion there. Does everybody who has a herniated disc need to have surgery? And number two, will the body over time reabsorb that disc material that's extruded?
Yeah, and you ask about the who gets better and why doesn't everybody get better. One of the mysteries of the body is that some people demonstrate a tremendous capacity to heal even fairly large disc herniations, both in the neck and the lower back. And they do this spontaneously. And the natural history of disc herniation is that it does improve. 85% of the time, if we follow a patient for about 2 years, we're going to see them do great. The problem is that during that 2 years, we have other obligations. You got to go to work. You got to mow the lawn. You got to keep doing regular things. And so a lot of people don't tolerate that without waiting around for that sort of thing. And that's where I think starting with things like physical therapy, doing gentle traction, that can really provide a lot of improvement in a fairly short period of time. And it's hard work. It takes patience and dedication, and you got to keep doing it. Nobody else can do it for you.
Right.
But follow through with that. There is a high probability that beginning usually around 6 weeks in, you'll see significant improvement. Now, as to exactly why is it that some people get better and other people don't get better, there's a lot of factors that go into it. And I think some of them are mechanical and some of them have to do with, is this an explosion of very low density fibrous disc material with a lot of clot and blood and that kind of thing? Or is this actually a chunk of cartilage which is broken off the end plate and is sticking into the spinal canal? That makes a difference. The other issue, some people seem to spontaneously heal on their own, and the disc just seems to get resorbed. Other people, instead of actually resorbing the disc, seem to have this physiologic reaction of laying down this calcium, which essentially creates a kind of a bony outgrowth, and that ends up permanently narrowing the spaces where the nerves run, which in and of itself may not be a terrible thing, but combined with other joint issues and other narrowing may result in a progressive syndrome that eventually, as they get older, can create pinching of the nerves. So it's a bit of a mystery yet, but I think that, again, starting off with a good, strong initial conservative effort to help them let their body heal, that's really the best thing. And assuming, of course, they don't have any of those red flags we talked about, it's a very reasonable thing to do. And one of the concerns is that, if you all of a sudden jump to MRI and it's reassuring, you want to get the MRI, you want to have that and be able to say, okay, I didn't miss something. The problem is once we get an MRI, we have to think about what does it really mean? And putting together the MRI with the patient's syndrome, it may seem straightforward, but sometimes it's a little bit more challenging than that. And many times we find that patients have findings on the radiographic images that really don't have any clinical significance. And sometimes that's a little bit of a conversation to try to convince them that, in fact, having a disc bulge is not associated with terrible things.
Right.
So that's one of the other factors we got to consider.
Yes. Let me ask you another question. If we're talking about nerve root impingement, is there a particular nerve root, let's say between C5 and T1, that you are more concerned with? Now, I do a pretty good job at teasing out which nerve root is affected. I have a special test that I developed called the Marquis maneuver that I utilize, and I'm actually doing a podcast about that, and I have videos about it on my YouTube channel. And I can really nail down which nerve root is most affected when it's isolated to one level. Now, is there a nerve root that is, let's say, wimpier than the others, or are there nerve roots that you are more concerned with? Like you see like a C5 controls the deltoids and it controls the biceps and supinator. Are there certain nerve roots that are being impinged that you might say, you know what, I think we probably should tackle this neurosurgically sooner than others?
Yeah, that's a great question. I think that a little bit of it has to do with the patient's specific experience and the severity of the symptoms. But I think classically in training surgically, we always worry about C5 as somehow being a little bit more delicate and able to be profoundly affected by what seems like otherwise relatively minor injury. Fortunately, most of those patients do very well with time and do get better, but it certainly affects all of your functioning if you have trouble lifting your arm above your waist. So that's a big one. I think from my perspective, I worry a lot about C7 just because of the fact that it really helps people's functioning of their hands. And as anybody who's ever had some of this type of a problem, not being able to use your hand well, particularly if it's your dominant hand, that's a big quality of life impact. And so, yeah, those are the two that I think I would really single out. But the reality is that every single one of them is of concern. And, fortunately, we see that's the majority of what we see, people who have some compromise of the structure that allows the nerve to become pinched, as people say, and compressed. And the good news is those nerves are delicate, but they are resilient. And if you give them time, you get the pressure off, and you do it in a timely fashion, they have a high probability of doing very well.
Yep. Great. And another question I have for you is, when considering doing surgery on somebody, like they come in, they have significant neural compromise, loss of strength, maybe a loss of reflex, loss of sensation, significant radiculopathy. And how much do you take into consideration if a patient is a smoker versus a non-smoker, maybe how much they smoke in regards to the type of surgery that you do, or if you even do surgery at all?
Yeah, that's a great question too. Yeah, smoking's not good for you. I think that's a newsflash there. It's funny. I had a professor of surgery, Carlos Pestana. He was a remarkable guy, still is. But he used to like to say that there were two species of humans on the planet. One was the non-diabetic, and the other is the diabetic. And it's because a systemic disease like that can really affect outcome profoundly. And it can affect healing and how people do. And it's true, diabetes does impact on how people do in spinal surgery as well. But smoking is very similar in that regard. And it's a tough thing. I feel bad for people who smoke because it's not easy to give it up. And it's not a judgment, it's everybody has their own issues, and we all get through things somehow. And, coping mechanisms differ. And maybe it's not the best coping mechanism, but once you're there, getting out of it is really tough. But absolutely, I tell them that your risk of complication, and not just any one particular complication, but every complication, is anywhere from 2 to 10 times higher. And yeah, that's bad. But most of the time when we're talking about surgery on the neck, we're really looking at pretty significant issues that are going to have big impact on quality of life in the long term. So we still are willing to consider surgery for people who are smoking. That's not always true in the lumbar spine, but in the cervical spine it is. But yes, every potential complication, from infection to swallowing trouble to bleeding to bone healing, all of that really is very negatively impacted. And the reality is that when somebody comes and they've been smoking for 20 years and they've got a bad neck and they blame their dog for knocking them over and they injured their neck, it's not the dog's fault. The reality is that smoking has negatively impacted their bone and joint health for many, many years, and it's a cumulative process, and that's the reason that they're having trouble.
Yeah. And I have a talk with patients, and I have a very serious talk with them about smoking, especially if I see them early on. I'm trying to manage them conservatively, and I'm thinking down the road, they may potentially need surgery. I talk to them about, the lack of oxygen to those tissues, the disc in the spine really starts to become less vascular over time anyway. So why would we want to decrease the amount of oxygen that your spine gets? And then with 26 years of experience treating hundreds and hundreds and hundreds of post-op cervical spine and lumbar spine patients, I do find that those who smoke and those who smoke a little bit more than others, the recoveries are a lot longer. It's difficult for us to get them into cardiovascular exercises, and we can't get them moving as quickly. And it just takes so much longer to recover. And so I really encourage those folks to, start a smoking cessation class, or doing whatever they can to at least decrease the amount of smoking that they do to optimize their outcome and quality of life.
Yeah, you're absolutely right. Everything you said is 100% right on. And the problem is that the nicotine, that particular ingredient that makes it so hard to get rid of, is really good at relieving anxiety. And there's another great way to induce anxiety, and that's to introduce somebody to a spine surgeon who's talking about operating on them. So it's a challenging situation for sure, but absolutely, the sooner they quit, the better they're going to do. And if you have a patient who you think has got some spinal issue, the best decision they can make is to quit. And as a practitioner, as a clinician, being able to help them in that process is absolutely essential. Yeah.
Great. Well, all right. Now I'd like to take a little break so we can hear a word from our sponsor. Thanks. Welcome back, and thank you for being with us. And again, thank you, Dr. Arredondo, for taking the time to spend with us. I still have a few more questions for you, if you don't mind, and we'll walk through those. And if any of you folks out there have questions for myself or Dr. Arredondo, you can always get in touch with me at orthoevalpal.com and go to the Get in Touch page, and that will hook you up to our podcast. So you get podcasts sent out to you on a regular basis. We do them every Tuesday. And if you have questions, I can forward them to Dr. Arredondo, and we can have a discussion and help you sort through some of those questions that you might have. So again, thank you for being with us. Now, the other day, we both had a common patient, and he had come in. He had significant radiculopathy in his arm, also having a lot of discomfort down in his left leg. And so we sent him down to you. You did surgery on him, and I met him a couple of weeks after surgery, and he said, Paul, he says, you're not going to believe this, but as soon as I woke up, it was the first time in 6 months that I did not have pain in my arm and my neck, but I also had less pain in my leg. And he says, my leg pain has gone away. He said, I feel better all over. Can you give some explanation why this would have gone down past the waist and given him some relief there? Or is it just coincidence?
Yeah, he just had an excellent physical therapist, I think. It turns out that as we talked about in thinking about myelopathy, which is essentially the syndrome of mild spinal cord injury that occurs with a sort of a chronic and a degenerative style impact on the cervical cord, that in fact leg symptoms like a lumbar radicular symptom are not that uncommon. The one study put it at about 13% of the time. So yeah, it kind of opens my eyes a little bit, because that gentleman, although he had some impressive weakness, and if I remember, it was a C7 primarily. That's something that I expected. I actually also expected him to kind of have some lumbar issues, because he's a big, burly, physical guy who works hard and has done a lot of traumatic and forceful things in his life. And when you have issues in your neck, it's a reasonable conjecture that you're going to have issues in your lower back too. It's the same spine. But so I'm pleasantly surprised to hear that he was improving. But at the same time, I'm also concerned, because what it means is that essentially he has some component of myelopathy, and myelopathy is a tough diagnosis. It's a tough disease. It unfortunately does not respond well to non-physical interaction. In other words, if you give a patient medication, that's not going to make their myelopathy get better. You can realign their chakras and cleanse their auras all you want, but that's not going to improve their compression of the cord. It unfortunately requires a surgical intervention, but the problem is, again, it's not like there is a a binary on-off switch. I think that there is a spectrum of very mild and progressive disorder, and I think he had a very mild myelopathy because he didn't have any of the reflex changes we would expect. He didn't have any of the other physical findings, the so-called Hoffman's, or what people call a Babinski's, or an extensor plantar response. No clonus in his legs, no spasticity, rigidity, no fasciculations, nothing to point to say, oh, this is really severe. Those findings really, a lot of times, are very late in the disease. He also wasn't complaining about balance and coordination. He was complaining about pain in his neck and pain in his arm and shoulder. But in any event, I think, that's the sort of thing that we have to keep in mind. And it's easy when we have somebody telling us it's my neck to think about their neck. But we have to keep in mind that if somebody's having a lot of complaints of lower back issues, and there's really not much going on down there from a mechanical structural perspective, it's reasonable to think about their neck as well. Some of the MRI centers in particular have recognized this, and they'll do a survey sequence of the neck just to kind of get an idea of what's up there. Right. One of my favorite stories is I had a nice young lady who came to me because she was having a tremendous amount of back pain. And when I examined her, I found out she was profoundly myelopathic. She had, positive Hoffman's, cross adductor reflexes. And in talking to her, I found out that, for about a year, she had been seeing a psychiatrist because about a year prior, she went to her family doctor and said, just all of a sudden, I feel like my body is not my own. Wasn't having any pain, wasn't having any weakness, wasn't having any other real problems, just didn't feel quite right. Couldn't put it into words more eloquently than that. And so her family doctor said, well, yeah, you should probably go see a psychiatrist because that sounds crazy. So she very dutifully saw the psychiatrist, worked through her issues, talked about her mom and all that, but just never got over that feeling. Well, when I found out that, and then she started complaining of back pain, so she sent to me, and I was happy to see her, and found she was myelopathic. We took an MRI of her neck, and sure enough, there was a giant disc herniation at C5, C6, compressing her cord signal chains, the whole thing. We did a surgery, a little disc arthroplasty, worked out great. She got a lot better. All of a sudden, her body was her own again. Yeah. And her back pain went away. So absolutely, it was one of those things that it happens. It's maybe not the everyday case, but we have to be aware that that kind of thing can occur. And there are even practitioners, and I can't recall the name of the gentleman in Seattle, but there are discussions that some patients that are diagnosed with fibromyalgia actually may in fact have what essentially is a very mild form of myelopathy. And it's this repetitive cervical percussion syndrome where the cervical cord gets mildly compressed on a repetitive fashion that leads to symptoms associated with fibromyalgia type syndrome. I'm not saying everybody with fibromyalgia has that, and I don't think he would either, but it's one of the things in the spectrum of what we see. And so it makes us pause and think. Don't discount things, and don't just say, oh, you've got fibromyalgia, there's nothing to do. Further investigation can sometimes be warranted.
Right. My cervical spine evaluations always include a Hoffman's test, testing Babinski, checking for clonus, and looking for hyperreflexia. And episode 34 that I had done just previous to these, I go through all of those, and we talk about cervical myelopathy and what they mean and how to perform the tests and what the tests mean and kind of what direction you should go in when you see these types of findings. So I will leave that at that. But if you are interested in understanding myelopathy a little bit better, I do a podcast, and it's episode 34. And so you should check that out. Now, many people spend a lot of money and a lot of time getting x-rays of the cervical spine. And can you talk to me a little bit about why having a cervical spine flexion and extension x-ray is so important and meaningful to you as a neurosurgeon when they do the flexion and extension with a lateral view?
Absolutely. Yeah. So x-rays are a cost-effective way to get an evaluation of the structure of the spine. And if you get a set of x-rays on somebody and there is very clear abnormal alignment, or bony dysfunction, then that really can raise your clinical index of suspicion to think maybe it's reasonable to proceed with more advanced and expensive imaging. But an X-ray is cheap and relatively easy to get. There's a lot of places and ways to do it. And I think one of the things that's interesting is historically, people have used the oblique views where essentially the patient holds still and the technician will circle around them with a variety of different angles in order to capture the foramen and the facets and that sort of thing. And I think that prior to CT and MR, that was probably a very useful modality. But now that we have those other modalities, a dynamic set of X-rays where you actually are having the patient flex their neck forward under their own power and extend their neck back again under their own power, it's a relatively safe thing that isn't going to create a lot of issue. They might complain of a little bit of discomfort as they do it, but it's not likely to cause them permanent long-term harm. And what it does show us, if they can actually give us a reasonable excursion, is how are the joints functioning in the neck? And in other words, is there a translational listhesis? Is there a motion of one joint, one bone over the other? And the issue to think about is that a large translational listhesis in the cervical spine can actually result in pretty significant narrowing and stenosis of the spinal canal, and that can potentially predispose people to have issues from spinal cervical myelopathy. So again, I think it's just a good idea to get into the habit of thinking about simple things and simple things you can do to rule in or rule out. And I think a set of X-rays is a reasonable thing. The static images, just looking at you straight on and from the side, it doesn't give you a whole lot of information. But once you add those two extra shots, a flexion shot and extension shot, now you can actually see not just what is the overall bony morphology, but you can actually see the movement and the function of the joints. So you may not get every patient to participate. If somebody's got really terrible neck pain, they're not going to be able to move their neck very far. That's okay. But it's still a reasonable thing to think about, and I think can provide a lot of insight. And I don't know that having somebody get all the oblique views these days is really all that essential. Yeah, it certainly doesn't hurt. Maybe a little bit of additional radiation, but it's not a large amount of radiation. But it's something to think about, and it's additional cost that probably has a fairly low clinical utility.
Right, right. All right, here's a tough one for you, and I know we don't have a lot of time. I have a million questions, but we'll keep probably just a couple more questions. Have you ever had difficulty identifying the difference between a cervical nerve root issue and a rotator cuff problem?
Oh gosh, yeah. These creatures travel together, don't they? Yeah. It's interesting because I see not infrequently that people have both. And I think that the mechanism is that if you have a mild chronic irritation of a cervical root, then you can end up with actually a progressive weakness of the shoulder girdle. And that weakness predisposes the shoulder to dysfunction. And once you start to have a dysfunctional joint, then more injury is actually more likely. So yes, it is a real diagnostic challenge. And I don't think that it's easy. I think, if you talk to 10 different surgeons, you'll get 15 different answers. The hard and fast is really hard to point to. I think that when you deal with profound weakness, when you deal with profound numbness, you are going to be more predisposed to think about a root issue, a nerve issue. But if you're really seeing pain only with motion of the shoulder, and it's isolated to the area of the shoulder, and it is associated with a profound tenderness of whether it's the AC or the glenohumeral or the bicipital groove, any of those little targets, that's something that I think I would look a little bit more to the shoulder. But the reality is that we're not like a GMC, pickup. We can't just pop the alternator in and fix it with one little thing. A lot of times, dysfunction in the neck is associated with dysfunction in the shoulder. And we just have to prioritize and think about what's the bigger issue.
Right. And I think that it can go just the other way around also. If a person has a rounded shoulder posture and a forward head posture, first of all, that causes a lot of impingement in the shoulder. But in order to look up and communicate with people, you need to hyperextend that neck a little bit more when you have a rounded shoulder posture. So I think that it can go either way, that you can have the nerve root compression cause some weakness in the shoulder and cause shoulder dysfunction. But you can also have a tight chest and weak periscapular muscles and then end up with poor neck posture. So almost, I would say 100% of our patients, pre-surgically and post-surgically for cervical spine, go through a postural program. We get those shoulders back, head up over the shoulders, and we try to open up those foramen by developing better deep cervical spine strength. And I think it helps both. And so we really make it a point to optimize that posture, but it's very, very difficult to tease out. And actually, episode, I think 35 that I have talks about tips and tricks and pearls on how to identify one over the other. And then I developed a test also that helps to tease that out also even better. And so it can be very, very challenging, but very rewarding when you can sort them out. And sometimes you have both, but that can be difficult to treat also.
Yeah, and you've got an excellent series there, and I congratulate you for putting this together. The reality is that even with the fancy electrodiagnostics of a nerve conduction study or electromyography, even that's not a definitive test. I mean, and we can have patients with a radiculitis that is not electrodiagnostically evident. And so it is a challenge. And if you think about their overall spinal alignment, absolutely what happens in the buttock at the gluteal muscle level, what happens in the lumbar spine does affect the neck. And if you have a patient that has poor sagittal balance, where they're keeping their chest, really far forward over their pelvis, their head is naturally going to come forward. And as you mentioned, that rounded, in the extreme form of the dowager's hump, that's something that absolutely will predispose them to more issues. And, I guess the long term, what we want to do is keep patients where we can keep their ear over their shoulders or their shoulders over their pelvis. And that has to do with activity. It has to do with taking the time to invest time, energy, and effort into keeping their body functioning well. And that's really one of the big takeaways. The closest we ever come to curing anybody of spinal issues that are degenerative, it's the effort the patient puts into it. It's exercise, and right. That's really the key.
Yes. Do you have time for one more question?
Absolutely. Yeah, go ahead.
All right. So cervical disc replacement in the cervical spine. Can you talk a little bit about, who's a candidate for the cervical disc replacement? What is the benefit of having it over a anterior cervical fusion? And if you could just chat real quickly about why you would do one over the other, that'd be great.
You bet. Yeah. So cervical fusion's been around for a long time, and it works fairly well to eliminate a joint that has become dysfunctional. And the issue with it is that unfortunately it immobilizes that joint. And as a result, it creates a little bit of additional mechanical force on the joints above and below it. So as a result, we've developed these artificial discs, which are really not artificial discs. They're motion preservation devices. And there are, I think, 7 of them now that are FDA approved, and there are more coming. And the issue is that they allow the joint to be essentially repaired to some degree, but the motion that's left is not perfectly physiologic. It's not returning them to their God-made state. But I think that it does allow patients, particularly more active patients and patients who have an otherwise fairly well-functioning spine, to enjoy the benefits of having a decompression and more fairly extensive one at that joint without suffering from the long-term effects of a fusion. Now, the catch of that is that unfortunately these devices are relatively new, although you can go back to 1955 and find that there were people working on them then. These devices really that are being used today have not that degree of experience. And so I think that, I can't tell somebody who's in their 40s if they have an artificial disc that when you're 80, it's going to be perfect. And that's really what gets to the crux of the issue. If we're trying to decide between one or the other, both are very good options. It has to do with patients' risk profile? How do they like risk? Do they like the known evil of fusion, where you end up, we've got a very well characterized system, we've got extensive data, we could go on for weeks and weeks talking about all the findings and all the data and all the studies, but in the end, there is this additional risk of adjacent segment issues, and that has to do with the risk for more surgery. On the other hand, you've got the artificial disc, which is a little bit of an unknown. How is it going to behave 20, 30, 40 years from now? We don't know. Nobody knows for sure. But it seems on the preliminary data that we have so far that these devices are doing very well. There have been a couple that have had some hiccups, but I think that most of the mechanics are now fairly well understood. So in the end, I think it's good for patients that are active. It's good for patients that are healthy. It's good for patients that have a relatively normal spinal morphology and that have good facet joints, so that are able to continue to function well. Other people who have really severe disease and bad joint function or instability, they're not going to do well with an artificial disc, at least none of the devices we have at this point.
Right, right. Well, this has been absolutely awesome. I just can't thank you enough for all the information you've given us, and I hope that for our listeners that they've taken away a few things today that can make the evaluation process a little more streamlined and have a better understanding and really more confidence in what to do when making a recommendation for your patients who have, a spinal cord or cervical spine injuries or symptoms that are kind of up in the air and you're trying to figure out what to do with them. So hopefully you'll feel more confident evaluating your patients and managing them, not just necessarily treating them, but knowing where to send them, when to send them. And, I hope that we can keep the right types of patients in the neurosurgical office. And like with us, we are an outpatient sports and orthopedics physical therapy clinic. We don't do very well with things like lymphedema and wound care and pediatrics. Those types of patients go to clinics where therapists do a very good job with those. So we hope to make sure that neurosurgeons get the right types of patients in their office to take care of the right people at the right time, and that when patients are treated conservatively, they go through the proper management before they end up in the neurosurgical office. And we really exhaust those conservative managements without causing injury to the patient and long-term, nerve damage or issues like that. So I think that we really got a lot of that in a little amount of time. We could probably do an 8-hour lecture on this. And I've actually done some lectures on C-spine and shoulder dysfunction, that CME lectures that take about 7 or 8 hours, but that's for another time. So if you folks have any questions, again, please contact me at Ortho Eval Pal. And Dr. Arredondo, anything you want to add before we get done today?
Oh, Paul, I just want to thank you for having me on here. And I want to congratulate you again on the excellent job that you and your team are doing, not just in putting these podcasts together, but also in treating the patients up there. And I really think that the reality is that part of the reason there are so many specialties and so many different types of clinical experts that are dealing with these issues is that it's tremendously complex and no one specialty has all the answers. So we have to work together as a team, and the best way to do that is through communication, and I applaud you for facilitating that and helping everybody learn a little bit more about it. Thank you very much.
Well, thank you for being on the show, and maybe at some point in the future we'll do something else on a different topic.
Absolutely. We could even keep going on this one.
That's right. All right, Dr. Arredondo, thank you so much for your time. I really appreciate it. And thank you to all the listeners. And please make sure that if you have any feedback for us, you go to iTunes or leave a rating and review. I would greatly appreciate that. We'd like to know how we're doing. And, if there's anything we can be doing better, we'd certainly like to do that for you. So again, have a great day. Until our next episode, take care.